Yes, ma'am. Audible.
Anybody? If you can assure me that I'm audible. Anyone? They can message me also.
Yes, ma'am, audible.
Can you see the screen?
Yes.
Okay, so basically this is just a glimpse of our course, that is sit back and relax, which normally we launch just before exam, because I understand that revision is always overwhelming when you have to revise 350 tasks. So this revision course is for 100 tasks, where we take 10 tasks every day, and you have to just sit back and relax, because I'm the one who is going to do revision for you, and I'm going to take only 1 hour a day. This we are going to launch just before exam, so just say October end, like from 21st October to 30th October. Okay. Today we are going to discuss, okay, so what we are going to cover in this course, mainly we brush up patient safety, patient communication, applied clinical knowledge, because these are the main domains which students find very difficult. And most of the students are not able to clear these three domains. And these three domains cover second part of the task. When I say second part of the task, I always divide task in two parts. One is the part one, where there is introduction, agenda setting, then HOPI, then routine information gathering, and then examination. Second part start mostly from BBN, then investigation, then diagnosis, then cause of diagnosis, then complication, then MDT, then management plan, and then ending the station. So this particular course is going to cover your second part of the task, which you start from investigation, and this is sit back, relax, and revision. So whoever is able to book and want to revise important tasks, here we are going to keep 100 important tasks, not going to be a routine task. It is going to be tasks which normally difficult to retain. Okay, so let's start how we make it. So this is task one, CMV. Very first thing which you have to remember, simple approach, when it is less than 24 weeks, cytomegalovirus, congenital cytomegalovirus, very basic thing. When it is less than 24 weeks, we offer amniocentesis first, then ultrasound. Though, if it is after 24 weeks, we always offer ultrasound first, then amniocentesis. That's the basic difference which you have to remember. What is the timing of amniocentesis? Is equal to 21 weeks or more than that, or 7 weeks after infection or more than that. So this is 7 3s are 21. So this way you can remember. Then we offer ultrasound to check if there is any fetal abnormality. So this is the sequence less than 24 weeks, but if it is more than 24 weeks and CMV is positive, first we offer always ultrasound to assess if there is any fetal defects and the severity. Accordingly, we offer amniocentesis if required. Again, it has to be more than 21 weeks or equal to. So if we are already talking about 24 weeks, so we can offer immediately, or 7 weeks or more than that if it is less than 21 weeks. So this is example, less than 24, amniocentesis followed by ultrasound. If more than 24 weeks, ultrasound, then amniocentesis. If patient is coming any symptom which is probably indicating that patient might be having CMV, if patient is coming after say booking test and both are negative, we don't need any further test. But patient is coming at booking itself and we are offering, and if it is negative, it means there is no CMV infection. Just reassure patient and no further action is required. Probably there is some other reason of all her symptoms. Remember that. Now, when index simple sample shows this, means patient is coming with some complaint, which is probably indicating CMV, and you are offering her blood test. We call it as index sample. Index sample means sample which we are doing in the present day. This is applicable for before and after 24 weeks as well. So for entire weeks of pregnancy, we apply same formula. When IgM is positive and IgG is negative. Then we repeat this serology after 3 to 4 weeks. If it is still showing same, that this is positive and this is negative, then we have to reassure mother that this is likely false positive, cross reactivity, no active CMV infection is there. Remember this slide. Now, if IgM is negative and IgG is positive, this you have done before 24 weeks in an index sample, means you have done this test today. Then what you are going to do? Nothing, because seropositive mother CMV reinfection less likely. So this is before 24 weeks. But same if we get after 24 weeks, approach is different. So as of now, this is applicable both before and after 24 weeks. Now we are talking about before 24 weeks. If it is positive, if it is negative, it means CMV infection is less likely. Now index sample. So now patient has come before 24 weeks. You are doubting cytomegalovirus and you have offered test and the blood test is showing that she has both IgG and IgM positive. So understood, if both are negative, I just repeat quickly, both are negative, nothing is required. If IgM positive, IgG negative, then repeat. If same, nothing is required. If IgG is positive and IgM is negative, patient mother is already having immunity against this, nothing is required. But now, patient has come with some symptoms and now it is showing that both CMV, IgG and IgM positive. Now what you have to do? To confirm the infection, we are going to check the booking sample. So we do retrospective serology booking sample, which we take between 8 to 12 weeks, right? And also we offer IgG avidity if applicable. This is to time the infection. Now what can be the scenario? So presently it is IgG, IgM both positive. But in booking sample, it is showing both negative. So this is post-conception CMV. This is very easy to understand. It was negative at the time of booking. Now say in 10 weeks, 12 weeks, 14 weeks, whatever week she is coming before 24 weeks is positive. So obviously this is post-conception CMV. This is very easy to understand. Where confusion arises when IgG, IgM positive even in booking sample. So it is positive in index sample. It is also positive in booking sample. Then how to differentiate? Then we offer avidity test. This is to time infection. How to remember? When it is high, means immunity is high. It means infection before pregnancy, reassure, no further follow. But if avidity is low, it means within 3 months of conception, periconception. So maybe 1 month, 2 months before conception also. So if we get something like this or this, means when IgG, IgM was negative at the time of conception, or when both were positive and low avidity, it means periconception. In both this scenario, what we offer? We offer Valaciclovir, that is 8 gram per day till amniocentesis. We also offer KFT because this drug affect kidney, but this effect is reversible. So once you stop, if there is any effect on kidney, it is reversible. How does it help? It only reduces the severity. So what is the risk? Risk is of vertical transmission to unborn baby. So this reduces the severity. This is not curative. And 8 out of 10 women become asymptomatic. Baby is also protected. Then we plan amniocentesis from 21 to 22 weeks for CMV PCR. So when you find this and this in booking sample, after having IgG, IgM in positive in current sample, then we have to start antiviral. We have to offer KFT. We have to make sure that 8 out of 10 become asymptomatic. This is only reduces severity. Don't forget that we have to offer amniocentesis. Till then, we will offer this antiviral drug. And this is your example. If low avidity, IgG, IgM is negative, so these two scenarios, right? Then it's a recent one or periconception, then we have to treat and test, that is amniocentesis. But if it is high avidity, it means it is probably preconception or past conception. So you have to reassure. This is your example. I hope I'm clear about this. Now, so now we have checked this test, and now we have to come to this conclusion that probably after conception, probably periconception. So what we are going to offer? Now we are going to offer her amniocentesis. What is the criteria? Timing of offer amniocentesis? Ideally 21, 22 weeks or 7 weeks from the infection, which we have read in the beginning. 7 weeks or more than that. So you can apply any of these two. So now coming to amniocentesis. Now we have offered her amniocentesis that is 21 to 22 weeks. Amniocentesis is negative, so we do not need any kind of further treatment, but baby assessment or neonatal assessment is important. So remember, there are 2-3 criteria where we do not need neonatal assessment, like if this is the situation, then we do not offer any neonatal assessment. If this is the situation, we do not offer neonatal assessment. If this is the situation, we do not offer neonatal assessment. Other than that, all the cases, even if amniocentesis is negative, means if this is the situation, if this is the situation, and we have offered amniocentesis, and amniocentesis is negative, so definitely we are not going to offer these all ultrasound and everything, but baby assessment after delivery we is still going to offer even if amniocentesis is negative. Remember that. That's very important, especially if somebody is appearing in part 2, even in part 3, because see, you are supposed to prepare a topic, not a task, because it's not necessary that they are going to give only before 24 weeks. They can give after 24 weeks. They can give patient is coming at 14 weeks, 21 weeks, 22 weeks. So you have to have these algorithm, these charts on your test. So you have to prepare topic, never prepare a task. Remember that. So now I made it clear that amniocentesis we are going to offer. If it is negative, you do not need any kind of follow-up. You can assure your mother, but checking baby is important. Now coming if it is positive. If amniocentesis is confirming fetal CMV, then what we are going to do? Then we offer surveillance with ultrasound, which is performed by everybody. Please mute themselves. Then we offer fetal medicine reference and fetal ultrasound by them to check if there is any abnormality. So detailed fetal ultrasound 2 to 4 weeks and MRI at 28 to 32 weeks, which depends upon this fetal ultrasound. So you will say that we will offer a spatial imaging technique, that is fetal brain MRI, approximately 28 to 32 weeks as per fetal medicine advice. Now understood? So we have done IgG, IgM. Now we understood that it may be periconception, it may be post-conception. So we have offered amniocentesis. Now amniocentesis has come positive. So we are offering ultrasound. So now next treatment is on the basis of finding of ultrasound. If baby is showing no sign of abnormality, like no effect of fetal CMV physically appearing on baby's ultrasound, then what we are going to do? Expected management, then performing regular scan, that is 2 to 4 weeks and 28 to 32 weeks. It's going to be same. But if baby is showing some mild or moderate symptoms of CMV, then what we are going to do? Surveillance is going to be same. under fetal medicine department, 2 to 4 weekly, am I right? But also we may consider this, well, a cyclovir, which we started here, 8 gram per day. So once you confirm that it is post-conception or peri-conception CMV, you immediately start and you wait till needle test. Needle test negative, nothing is required. Even needle test positive, asymptomatic, nothing is required. But if it is mild or moderate, we may consider to continue this medicine. But if it is severely affected, then definitely you have to debrief patient and birth companion about the condition and how compatible this baby is going to be with life. So we offer termination. You will not say that we'll suggest. You will say in your task that as it is showing that baby is severely affected, Sarah, the preferred option is discontinuing pregnancy. Simple. Now, I hope you all understood these 3 points. Am I clear about this? Anyone? Am I clear
Yes.
about this? Yes, good. Well,
Yes.
well. So now what we do after delivery applies to all cases as we have discussed, even if it is asymptomatic, mild, moderate, or even if it is negative amniocentesis, but CMV was this, CMV was this. So even if it is negative amniocentesis, the after delivery neonatal assessment is very, very important. Placental examination, which we do in all the cases, whether asymptomatic, whether mild, whether moderate or severely. Why? We do the placental examination to confirm CMV, postmortem only if baby is dead. Neonatal assessment is applicable in all the cases, even in negative amniocentesis. How we do neonatal assessment? Clinical, bioclinical, audiological, ophthalmological. These 4 evaluation we offer. And accordingly, we offer management. What is the treatment plan? This is here what we offer. Valaciclovir. Here what we offer? What we offer? Valganciclovir. So remember that. This is acyclovir. This is valaciclovir. Here it is Valganciclovir. There's difference between two. Remember this. And here what is the dose? 6 mg per kg twice a day. Here it was 8 gram per day. 8 gram per day. And here it is 6 milligram per kg twice a day and long-term follow-up. So what is our example? Monitor disease progression, consider treatment when appropriate, optimize neonatal outcome. Okay. Now, so am I clear about less than 24 weeks? It's very easy. Hana, Dr. Hana, Dr. Aparna, Ina, VM, Sangeeta, am I clear about this? Radhika, Shruti, am I clear about this?
Yes, ma'am.
Good. Now, if patient is coming after 24 weeks of gestation, and patient is coming after 24 weeks of gestation, this is the first result. Index means immediately whatever you have, test you have got done for her. There may be 2, IgG, IgM negative, IgG positive, IgM positive, IgG negative. This we have already discussed if both negative, right? This both negative. Or we have also discussed if IgM positive. So there can be only 4 possibility, right? Both negative. If IgM positive, IgG negative. So for this, I have already explained. So I'm not going to talk about remaining 2 scenarios. What are the 2 remaining scenario? IgM negative, IgG positive, or both positive. If IgM is negative and IgG is positive, then we are going to again go back for booking sample. That is 8 to 12 weeks. And if reports same that IgG was positive, IgM was negative, it means it was preconception infection, no further action required. Ignore this. This I have added here, so ignore this. So this is index. Same in booking, nothing is required. So we are clear about both IgG, IgM negative. We are clear about if IgM is positive and IgG is negative. We also have clear approach about if IgG positive and IgM negative. So three scenarios we have already discussed. Now the fourth scenario. 99% they are going to give you this scenario. In index sample means the sample of today, both IgG and IgM positive. Again, what we are going to do? We are going to check the booking sample and the avidity. Now, what can be the result? Result can be same. That even IgG, IgM was positive at that time. Even IgG, IgM was positive at that time. Then what is the criteria to differentiate? Avidity. As I said, if it is high, means high immunity, means preconception infection, no further action is required. But when it is low avidity, it means a recent infection. Or in booking, if it is showing negative, then it's so simple to understand. If it was negative, it means first she got her IgG positive, eventually she got her IgM positive, then IgG positive, because IgM takes around 12 weeks to convert, and then eventually it becomes negative. Right? So definitely this is a current or recent infection. Third is what? IgG is positive, IgM is negative. It means at that time IgM was negative. It means she got another infection during the pregnancy. So I repeat, if both are positive, then we are going to go for booking sample. We will also check the avidity. If still IgG, IgM positive, and when there is high avidity, it means total assurance, no further follow-up is required. But if it is low avidity, in that case, it is recent infection and we need to do the needful. Same if it is both negative, we have to do the needful. Same if it is IgM is negative, we have to do the needful. So here we are not going to do anything, but here, here. What we are going to do? We are going to refer. Here, you will also remember this. Just ignore this. So now IgM is negative, IgG is positive, right? But in booking sample, both IgG and IgM was positive. You will going to apply same formula. When IgG and IgM positive, you are going to apply same formula of avidity. So remember that when it is negative, it is positive. Either it could be same, nothing is required. But if it is both positive, then you are going to apply this formula. Just ignore this. Apply this form. Okay. So now it's low avidity. Now it's both negative. Now it's IgM negative with IgG positive. We are going to refer to fetal medicine for targeted ultrasound. Targeted ultrasound shows nothing. Then 4 weekly. Here we were offering 2 to 4 weekly. But after 24 weeks, it's 4 weekly. Neonatal CMV PCR you are going to offer here. Remember that. Remember that. This is the situation. Even after this, this is the situation. So you're just taking it this way. You have to offer ultrasound every 4 weeks and neonatal CMV PCR as we have discussed. God forbid, if there is abnormal ultrasound, it means congenital CMV suspected. So here what we have discussed first, see in both the cases, whether it's less than 24 weeks or more than 24 weeks, the very first thing we do the blood sampling, that is the recent one. Then we follow the booking blood test. After that, if it is less than 24 weeks, it's always amniocentesis first, followed by ultrasound. But if it is more than 24 weeks, again blood test, index, and the booking is going to be first step. After that, scan is the second step, not the amniocentesis. So we are offering ultrasound. If ultrasound is normal, ultrasound is always done by the fetal medicine. Remember that. And ultrasound is normal. So every 4 weekly, this will be done only by fetal medicine. But if ultrasound is abnormal and suggestive of CMV, then what we are going to do? Then we are going to do index simple IgG, IgM, and this. So here there are two things. First, we are doing this and then we are offering the ultrasound. Second, by chance, test was not done and she was due for her routine scan and routine showed some abnormal ultrasound. So there are two things which you have to understand. So this is a by chance you are performing a scan and then you find there is some signs which are suggestive of CMV, then you are offering maternal serology and this and that, then you are going to offer amniocentesis. This is the first one. This is an incidental finding or accidental finding of CMV in ultrasound. Then we are going to offer this IgG, IgM, and then accordingly we are going to offer amniocentesis. But if we are following this one, that we are already patient has been diagnosed with CMV as per serology, then we are offering ultrasound. Ultrasound is normal, we are going to offer this. But if ultrasound is abnormal, then we are going to offer amniocentesis or CMV PCR molecular chromosome testing to confirm fetal infection. So now there can be two scenarios in your exam. The first scenario is that patient has come with say some 20-week scan, right? Patient has come with some 20-week scan or any scan by chance being offered after 20 weeks, because normally if it's a low risk pregnancy they do not offer after any 20 weeks, but for any damn reason they have offered a scan and that was performed say, around 24 weeks and whatever, and in that scan by chance, so there is no history of any CMV infection, fever or anything, there is no history of any blood test, now patient has come with this report and the report is suggestive of CMV, then you will follow this, that we are going to offer index sample and accordingly booking sample, right? And then if it is IgG positive, IgM negative, IgG negative, as we have read here, right? IgG positive, then IgM either positive or negative, then there is high risk of congenital. Remember that this is after 24 weeks. So even after 24 weeks, if IgG is positive and IgM negative, still it can be a recent infection. It can be a post-conception infection. Why? Because IgM takes around 12 weeks to convert in IgG. So just suppose if she caught this infection somewhere around say 10 weeks, 10 weeks. So you just add 12 weeks, at 22 weeks, IgM will become negative and IgG will become positive. So if IgG is positive and IgGM is negative, IgG is positive and IgM is also positive, and this is the current sample. This is the current sample. She is already 20 more than 24 weeks. This is we are talking about more than 24 weeks. We're directly going to offer amniocentesis. But if index sample, that sample we have conducted today and it is negative, then we will consider it could be some other infection. Understood? So there can be two scenarios. First is 26 weeks, 27 weeks, patient is coming with symptoms. GP has already done index sample test. So this is the sample report. Then you are going to offer this booking sample. Then you are going to offer ultrasound. Then you are going to talk about if abnormal ultrasound, we have to offer amniocentesis. Clear? But the other scenario is that is an incidental finding, that CMV some sign and symptom, then you are going to get the test done immediately, and on the basis of this you are going to offer amniocentesis. I hope I'm clear. This is little tricky, but I try to make it simple. Am I clear about this? Am I clear about this? Any
Yes.
questions?
Yes, ma'am.
Ma'am, I have a question from the beginning, starting slides.
Mhm.
You said when if it is IgM positive and IgG is negative,
Hmm.
then we repeat in 3 weeks. And again, if IgM
This
is
you are talking. This you are talking.
no the
IgG
previous
positive, IgM
before
negative.
this, before this.
Huh. This one when
Yes,
IgG
ma'am. Yeah.
positive, IgG is negative. Yeah.
Yes. So I'm saying IgM usually indicates acute infection. So why do we wait for 3 to 4 weeks?
This
Don't we
is
give
how it
treatment?
is given when IgM is positive and IgG is negative. They always
Mm-hmm.
advise to repeat after 3 to 4 weeks. If it is still same, they
So.
consider it as
Mm-hmm.
cross reactivity. This is the guideline. And this is
Okay.
applicable both for before and after.
So
Okay?
in the interim period, we do not give any treatment to the mother.
No. We repeat it after 3 to 4 weeks. This
Mm-hmm.
is the
Okay.
guideline. Okay?
And so, ma'am, even after 3 weeks, if it's still coming positive, it still is showing infection, right, ma'am? So why are we reassuring her?
If it is still after 3 to 4 weeks, same. So it is reassuring. For them, it is reassuring because after 3 to 4 weeks, probably it will come either negative. So if it is still showing positive, it means cross reactivity. Cross reactivity is very common for CMV. So it's not an active CMV. We always only look for active CMV, not for cross reactivity. This is an indication of cross reactivity. These are the guidelines. These are the algorithms. Okay. Just go through CMV new talk, which they have published in 2024. Okay.
Okay.
Yeah.
Okay.
Okay. So where were we? So this we have discussed. Now, how we do this, as we have just discussed, that there are certain points where we need to do neonatal assessment. Neonatal assessment, how we do? Either we take baby's urine or saliva, that is within 21 days of delivery, to confirm presence of CMV PCR. Okay. Severity depends on the gestational age at maternal infection. Obviously, when mother catches this infection within 12 weeks, then the more risk of having baby this congenital CMV, and the severity is also more. So what is the most important period? That is 12 weeks, first trimester. But what we check for baby, we check baby's urine or baby's saliva. We do not take anything else. Now, CMV virus is only harmful in pregnancy when it is active. This is what I was talking about, Shruti. We always look for active infection. If there is cross reactivity, and how we diagnose cross reactivity? If IgM is positive and IgG is negative, and again we are repeating after 3 to 4 weeks, this is the criteria, this is the guideline which they have made. So it means it's a cross reactivity and we do not know, we do not need any. And it can pass, so it's only dangerous when it is active because it can pass on to unborn baby. What unborn baby can have? Hearing loss, brain development problem, smaller head, fits. Some parts of brain are larger, learning difficulties, swollen spleen and liver, problem with eyes, rashes, yellowish discoloration, many a time defects so severe that not compatible with life. So when you discuss about CMV to your patient, that why you are so concerned about whether it's an active infection or not, because it can cause so much, or it has so much detrimental effect on the baby. So you are going to, and Baba, she may ask, so I also concerned about it. Is it going to affect my pregnancy? It is not going to affect patient per se. She might be having some symptoms, but for baby, it can be very dangerous. So you will say that baby might born with hearing loss, smaller head, brain development problem. Some part of the brain may be larger, maybe learning difficulties, swollen spleen, liver, or some organs inside. Some very important vital organs may be swollen, problem with eyes, rashes. So that's why we are concerned about this condition to confirm whether it is active. If it is active, in that case, we have to follow certain steps. And then you are going to explain her what all steps you are going to offer her. This we have already discussed, that how we give treatment to a mom. This we have already discussed, that risk is more to baby if you are pregnant, having it for the first time, and if it is before 12 weeks. What symptoms mother can come? With high temperature, with aching muscles, with joint pain, with tiredness, skin rashes, feeling sick, sore throat, and swollen glands. So if patient is coming with all these symptoms, then also if GP has not performed any test, you have been called in emergency because patient has come with the high temperature, and you are taking her history and you're asking any other symptom apart from high temperature. If she says that I'm having joint pain, my muscles are aching, I feel so tired, I'm also having sore throat, I feel sick, I do have some skin rashes, then you will first think about CMV and you are going to offer CMV test, that is index, recent time, and then you are going to compare with past time. Probably now even tasks are quite dynamic and evolutionary. It means when you say that we are going to offer you this test, probably examiner will give you another paper where they will show that you have performed the test and index sample is showing IgG this much, IgM this much. Then you have to take the task from that point onwards, that you are going to take the booking sample and going to offer her blood test and avidity whenever it is applicable. So that's all. This is all about CMV. And this is how you have to revise, because just before exam, you have to revise what are the important point in the treatment which you have to mention, because that is applied clinical knowledge. If you are giving right diagnosis, if you are telling right complication, and you are addressing patient concern about why this condition is so important to understand or address, that is patient communication, patient safety. Anyways, if you are not able to diagnose CMV, if you are not able to understand that or address that now we have to offer booking. If you are just talking about, say, if you go here and you just talk about uh, these tests, right? You talk about these tests, but you do not talk about booking blood tests. You just take decision on the basis of index sample that IgG, IgM is positive, and now you're moving forward with this. This is affecting your patient safety because you are not having the right approach. So second part of the task include all three domains, and these all slides mainly going to cover your second part of the task. Okay, so that's all for today. Any questions?
Thank you, ma'am.
Any questions? Should we wind up?
Thank you, ma'am, for such wonderful session.
Thank you very much. Okay. Keep practicing. Bye-bye. Take care. Good night.